Wendy many years ago, and she was always very interested in innovation and always very interested in publishing. And we both used to work at Bath, and Wendy left to go to UE, where she has set up a research centre, which is obviously part of what she's going to talk about today. And she has been extremely successful with bringing in Research Council funding. And obviously the theme of redistribution is, you know, one of the commonest themes. Things get dispersed, and then everybody believes in concentrating things, and then the pendulum swings again. But there are different reasons now, perhaps, that redistribution, or not having a centralized system is the better way, with other pressures that I'm sure Wendy's going to talk about. So thank you very much for coming, Wendy, and the floor is yours.
Thank you very much, and thank you all for being here on a very cold Friday afternoon. So as Nigel has said, I am Professor of Innovation at the University of West of England, where I've worked for more years than I'd like to think of now, but prior to that was at Bath with Nigel. I'm currently the head of the Innovation, Operation Management and Supply Group at Bristol Business School. But what I'm going to focus on today is actually a research project, or several research projects that I've been leading for nearly 10 years, when we started the Redistributed Manufacturing in Healthcare network, which you can see the logo there bandied on the left-hand side. And this is a network of experts in healthcare that are very much focused on how we can employ advances in healthcare technologies, and not just healthcare technology, but technologies generally. So additive layer manufacturing, big data, advanced cell therapies, and changes in materials to promote improved delivery of healthcare. So it's not only developed for the persons, or customized or personalized, but it could be closer to right first time treatment where you want it, so close to the point of need or point of care. So the RHINE network was established, as I said, nearly 10 years ago through funding from the Engineering Physical Sciences Research Council. And I did put the grant code there, but it seems to have disappeared off my screen. But nearly 10 years ago, there was recognition of the fact that advances in technologies would mean that we'd be able to move towards a situation of producing goods and therapies close to hospitals and clinics. And it was also not only limited to healthcare, but also looking in terms of food, which is very salient now, as we're increasingly aware of the lack of resilience within the UK food supply chain. And there are other areas that were looked at to look at where we could try to promote this move towards close to the point of need manufacturing, or redistributed manufacturing. And I was lucky enough to be awarded a grant to look at this in healthcare in general. And we were given, if I move to the next slide, we were given some funding to look into this, and we focused on some key areas, which I'll go into later. At the time, we identified that there was potential value in moving towards a redistributed model of manufacturing. But when we sort of had discussions with the National Health Service, it was felt that the centralised economies of scale, so mass production, standardised products, was more economic for them. That was all prior to the pandemic, when then suddenly it was realised that when we're relying on global value chains, and protecting sovereign interests came to the fore, where you saw nations safeguarding critical healthcare products. We saw lack of resilience in supply chain when lockdown meant that critical goods could be supplied across borders, but also they didn't have the drivers to be able to, take trucks of goods across countries. And we just saw how relying on long, lengthy supply chains could really put us in a situation, well, it did, of where we didn't have the products that we needed when we needed, and we saw the impact that had on healthcare delivery. So that has actually focused more attention onto redistributed manufacturing. But at the end of the project, we were given funding to focus what at that point was seen as a high value areas, which was deployed medical care, which is what I'm going to focus on now, because that's where I've been researching for the past 4 years. And it was felt that in the areas of humanitarian aid, defence medicine and emergency medicine, it's a criticality to have products within that golden hour of an incident and not have to rely on lengthy supply chains that could go through countries and nations where there may be disruptions in the supply chain due to, as we see, climatic events, geopolitical events, and the recent crisis in Ukraine has highlighted how conflict can impact on supply of critical resources. So we're given funding to look at deployed medicine, but in terms of looking at redistributed manufacturing, the picture I've got on this slide here shows you the traditional model where you have a centralised manufacturing facility, which will mass produce some goods, very generally standardised, package these goods, transport them to a hospital where they will be stored and given to the patient. And that manufacturing unit, as I said, could be in another country, overseas. And the packaging, you think of the waste within the packaging, that I'll go into more detail. Then there's a need to transport either by truck or by air or by ship. And to a storage location, which isn't always a hospital generally, and give rise to large inventories, and eventually it will get to the patient. So then motion is actually to manufacture when you need it, where you need it, and try to avoid this large scale. So it's about scaling out as opposed to scaling up, and moving the manufacturing facility on the means of manufacturing the product close to the patient. So if we think of 3D printing, producing prosthetics, face masks, so forth, close to the pain point of need. Another area we've been looking at is advanced therapies, so manufacturing of skin products, wound dressings, which use biological material that could be produced specifically for that patient, so to avoid the risk of rejection, and could be produced close to where they need, avoiding the risk of a cold chain, which is as we're talking later, is very much exposed to disruption, and you see up to about a third of products, loss of a third of products during transport via cold chain. So it's about trying to move manufacturing close to the point of need. So we produced a white paper, which is there in the left, and one of the key findings was actually an interesting future possibility were to take redistributed manufacturing into mobile or flexible locations in cases where there is an acute and urgent demand for medical products or supplies. On the back of this white paper, the recommendations have been used by the MHRA, who you all have heard about during trying to get vaccines swiftly through during the pandemic, but in terms of trying to change regulation to enable this redistributed manufacturing model, or this manufacturing at point of need. Currently, the regulation is very much focused on ensuring quality and efficacy at large-scale production facilities, which is much easier to do. The issue is, how do you ensure that efficacy and quality across multiple thousands of sites? And luckily, with digitalisation of data and real-time monitoring, we're able to move that way. So the UK are leading in having this new regulation, which is about to come out, allowing point of care manufacturing. So if there's a positive to come out of Brexit, is that they were able to swiftly move this regulation through. The negative is that Ireland, without anybody in charge at the moment in Northern Ireland, haven't been able to push it through so quickly. So I think they're going to have to go without Ireland at the moment and wait to roll it out there. Anyway, moving on to the next point. So I think many of you are probably very familiar with redistributed manufacturing by now. It's been, when I first started, it was a novel concept and people couldn't understand how it would work. But with the COVID pandemic, suddenly seeing repurposing manufacturing facilities, produce PPE, to produce other critical healthcare products, showed how you can move production swiftly to a closer production facility. So by producing smaller scales closer to the point of need, we can improve efficacy and quality through ensuring we're producing something that's specific to the patient in most cases, because we're able to use customer, the records, patient records, 3D printing and so forth, to produce a product that is fit for purpose for the patient. And can be produced near to where they need it, so they won't have to travel either a long way to the main hospital that can deliver the care that they've had previously. And in an extreme case, we're looking at situations where they can produce the products at home. We've been working with pharmaceutical experts to look at how you could print drugs and pharmaceuticals and print drugs that have multiple different drugs within a tablet, and that the tablet could release the drug over 24 hours, reducing the need to take multiple pills and also the worry about, oh, I've got to take one every 4 hours or so forth, because through this specialized combi pill printing using 3D printers, we can move that way, and that's one of the areas that we've been looking at. And with improvements in data monitoring, digitalization and so forth, we're able to move from trying to forecast need to actually producing what we need when we need it, making it to order rather than to stock, and knowing where it is at all times through the supply chain. So ensuring improved capacity management and allowing more resilient supply chain. I talked again earlier about personalized medicine, but it's enabling ways to try to produce products that are specific to the patient, whether it be through fit in prosthetics or through biological material in advanced therapies, or whether it be, as I said, drug doses in pharmaceuticals. And we're trying to look at ways to break this large global value chain and this dependency on major manufacturers who could be miles away overseas, and move it more to onshore, close to the point of need, and complement different existing ways of delivering some practices such as pharmaceuticals and so forth. So that's RDM, or a quick run through RDM in healthcare. The past 5 years, I've been focusing, as I said, on deployed military operations. So if you see the acronym DMOs, not military deployed medical operations, DMOs means that. So what the highlighted recent events, if you even look at the news now, what's going on in the Red Sea and how that's disrupting current supply of not only critical healthcare products, but you're hearing about Tesla and other manufacturing companies who are unable to get critical parts, and it's holding up their ability to deliver goods. So there's hold-ups in the supply chain. So there's recognition that there's an urgent need for a resilient supply chain. We can just see how here with severe weather conditions in the UK, but even more severe in other countries, how that can impact on the ability to deliver goods. Not knowing in terms of geopolitical uncertainty, so trying to avoid reliance on manufacturers in countries where potentially we may have adverse relationships in the near future, potential for conflict. The impact of terrorism, you'll see a sudden surge in demand for critical products and those incidences, so it's a need to rapidly be able to deliver those products as a result. Natural disasters, so look at the impact of the volcanic eruptions in Iceland, and you can see that their ability to transport goods and so forth are really impacted, and the ability to fly goods in the air zone around there. I don't need to talk about pandemics. I think we all know the impact that had on healthcare. So for deployed medical operations, there's very much a need to target and deliver immediate care. And the situation that they're focused in is it's very resource austere, unstable situation. So they may have limited ability or access to power, to water, and to other resources, but it's power and water one of the key components. And it could have extreme heat or extreme cold and adverse weather conditions. So there's a lot of issues they have to consider when they're going into setting up a deployed medical operation. What they want to do is move it far forward as possible, close to the point of need in the supply chain, so they're not reliant on having to order goods from overseas and transport those over long distances where there's a major issue of potential disruption and delays in supply. So the big focus for deployed medical operations is minimizing the logistical tail and trying to move away from a reliance on global value chains. So over the past few years, I've been running a close to £2 million project looking at redistributed manufacturing and deployed operation. And as the tagline or vision says at the top, we were seeking to identify, fund and advance high value applications of redistributed manufacturing research that will transform future deployed medical care capability. and having run a workshop that was funded by the EPSRC. So if you're looking at funding, in order to get larger scales funding, start small. So we got for this one, we got a £15,000 workshop funding from the EPSRC to look at potential applications for RDM in deployed medical operations. And from that workshop, we identified 6 key themes that we wanted to focus on. And based on what we found, we're able to ramp that up into a larger Network Plus program. So the first line was a network program. If you're able to show that you can deliver value building on that research, but in a more applied area, they will give you Network Plus funding. So that's how we got the funding. I can't see people asking questions, so if they are, Nigel, you have to jump in. The key themes that were identified were to focus on additive manufacturing. So the use of 3D printing and additive layer manufacturing to produce goods at the point of need. Cell and tissue therapies, particularly in the area of wound dressings. Clinical fluids, which really did surprise me. The major demand they have is for water, and I'll go into that later in detail, but they have to fly water in the first 6 weeks of an operation. And that's hugely expensive, obviously. And the other issue is blood and plasma. So we'll look at that as well. And pharmaceuticals, they'll have a huge stock, an array of critical drugs that will need to deliver. And the problem there is when those go out of date, they have to discard those following the regulations of the nation that they're based in. It leads to huge wastage. A lot of these have to either be flown back to the UK or the country that's the main host, or they will have to be incinerated or disposed of in other ways, which is massive waste. So if they could produce the drugs that they need when they need them at the point of need, they'll be able to reduce a huge amount of waste and reduce the inventory. So we had those 4 areas, and then over that we tried to look at what the requirements were and look at what developed the business case for it. And so it extended upon the original focus, which I was down there, the grant that started in 2015, where we focused more on regen, med, pharma, and medical devices. So the context for deployed medical operations, they're often treating casualties in challenging locations around the world, often in response to climate change, so dealing with floods, fires, earthquakes, conflict and terrorism, and pandemics. Usually the environment is very unstable, can rapidly change, whether that's due to conflict or weather conditions, hazardous, and they're very limited to what they can take with them. So they have to think very carefully about what it is that they need and how they can store that products, because a lot of them these products have to be stored refrigerated, which is a major drain on power, and power can be very unreliable. So if that's lost, then the refrigerator stock can stop working, and that could be a loss of product. Trying to move the ability to treat patients almost immediately, and then move them back to a safer location, but that's not always possible. And so it's trying to move the ability to treat patients and deliver products close to where the injury is. In Afghanistan, the allies there had air supremacy, so they're able to set up a very, very big medical facility and not worry too much about getting they're able to get to the patient, get the patient back, and getting goods across there was much easier. So they had on ratio 100 medics to 1 casualty. The Ukraine crisis, they cannot set up field hospitals that are stable. They have to be moving constantly because the Russians identify where they are. And the ratio that we heard at NATO was that they had 1 medic to 100 casualties, and they have to move very quickly, flexibly, and it's very different, the nature of the wounds there. So they're very concerned about how they can move manufacturing close to the point of need and make it flexible, because they're going to have to constantly be moving before their whereabouts is identified. So the main focus for supply is minimizing the logistical tail and bringing critical healthcare products and production close and far forward in the supply chain. So this is for defence, and there is humanitarian as well. And this is just to give you a point of understanding of how it looks for them. And they have the hot zone, which is where the patient is critically or is injured. And then that's where there will be a medic who will try to administer first aid as quickly as possible, so to try and deal with hemorrhage, shock, hypothermia, and then try and move them back as quickly as possible past what you see there, it's a clean line, to a deployed hospital care facility. There will be some doctors there, there'll be an ability to stabilize the patient and then get them to a hospital near the rear where it's more secure. They've got much more resource and facilities and medics to treat the patient and hopefully get them back on their feet. In the more severe situations, they're being repatriated back to their country, which is what we call Role 4. And based on this diagram, it was felt that there's areas for redistributing manufacturing to add value in this tactical field care, so near that first point of injury. And there's a golden hour where you have to treat the patient and try and get them secure and stabilize as quickly as possible. So if they can improve healthcare delivery in that golden hour and try and look at ways in which they can deliver some products that can't be delivered at that point, then they could see an improved outcome. So one area we're looking at is how they could potentially deliver blood in this situation. Blood has to be maintained at a certain temperature. At current situation, they can't take it with them. So we're looking in the current project, freeze-dried blood, other ways of doing that, so that maybe they can deliver something to help the patient. Other areas is back behind that line, improving the care there in terms of wound dressings and so forth, and within the deployed hospital setting. So they're key areas where RDM could deliver value, and that was areas that they were concerned about, and that was where we had to try and think about what would it have to look like, new technologies if they're going to operate in these areas, because you can have a great product, but if it can't work in a situation where you're dealing with minus 20 degrees or plus 40 degrees, then there's, it might be, there's no capability, it's not adding any value. So it's thinking about these operational requirements in these situations. So our key research questions that we're looking at were, what are the operational requirements for redistributed manufacturing? Where is it most likely to add value, and what are the priority areas for future research and development? And I will emphasize, although I gave you the model of defense, that's just to give you an idea of how it can look. You've got that critical goal now, and then you'll have hospitals further back that are more secure. So we work with humanitarian emergency services as well in order to address these research questions. So the first one was identifying the operational requirements. So it's trying to get a very clear idea of what the end user needs are. So we drew on element of systems engineering, looking at requirements engineering to develop an operational requirements document. So it's trying to define a problem without presupposing a solution, and look at standards against what they have now, because you've got to maintain that quality in delivering new products, ensuring that those needs are met, and trying to understand what the challenges are along that pathway to minimize assumptions and missteps. So we funded several feasibility studies, and the clear steer we gave to them all was, you need to think about using this in a resource austere environment. So some feasibility studies didn't get funded because they didn't think about the challenging conditions that these technologies would be operating in. And if they don't work in those situations, they have no value to deployed medical operations. So it was thinking about that. So it was very clear that we need to establish what those operational requirements were using this methodology. So we came out with predictable needs, so the core requirements that you would see across all contexts and situations. And then there may be, so that'll be delivery of power, water, ability to deal with surges in demand. And then situational requirements that may change. So humanitarian aid is very different to how they respond to defence, who in a humanitarian situation, they send out quickly a team to scope what they need, what resources are available locally, what they need to bring with them, and so forth. So they'll have different requirements. It was clear that we understood what the requirements were and how they differed across the key sectors, but also what were the core predictable ones that in any situation they would be confronted with. So in terms of understanding for redistributed manufacturing and the applications that can be developed in future, the core requirements mean that they have to be ruggedized, they have to be robust, durable, and function. You imagine it's going to be chucked in the back of a Land Rover over bumpy terrain. Somebody will just bang it down. You have to have a situation where it can deal with those circumstances. So looking at 3D printers, they have to be quickly calibrated or easily calibrated or not need to be calibrated after transport, because they are going to be bounced around and so forth. And whether they can deal with extreme temperatures and humidity and so forth. A huge issue is power, so they need low power requirements and be able to be resilient to power fluctuations, particularly for the ones that are used over a long period of time. So the key goal is to ensure that any product either had a reduced power footprint or could work independently through other means, and that solar was one, but there's other new technologies that others were looking at. When you're out in the field, you're very reliant on the resources you have there. You're not going to have skilled workers who understand the technology, so they need to be simple and user-friendly, so that can be used widely, and you'll be working, or they will be working, partner organizations. So there's a need for different people from different countries with different skill sets to be able to use the products and not need a high level of training to use them. A big issue is, when things go wrong and you need to fix them quickly. So there have to be something that easily fixed. You don't have to wait for supplies to be flown in from overseas or from elsewhere to make sure that it keeps working. As I said, they're moving around. They have to be portable, and so low weight, not bulky, so they can quickly move them where they need them, when they need them. Modular, so that potentially you can scale them up, scale them down, and look at other ways, repurpose them in different situations so that they can deliver surge capacity and be responsive to situations. So we produced a report which you can access on our website, but these are we looked at the requirements here and came up with a traffic light system for what were the key elements, because in humanitarian, military, emergency, what some sectors would deem really important, others wouldn't seem as quite so important. So I'm not going to go through all these in great detail. I'll pick out some of them and go through some detail about the conditional requirements that you see aligned with each of these products. So the first one I was going to pick out is telemedicine, which for humanitarian aid and military aid is hugely important when they're overseas elsewhere, less so for emergency because they'll be in their home nation, so they can probably relatively easily access specialists quickly and get them to a main hospital where they'll be a specialist, or they'll be able to get to the scene by an air ambulance, or you see the ones driving quickly in cars when they need them. So it enables remote consultation with specialists, so there could be a expert in hemorrhage or something overseas at a UK main hospital. So for the UK, that'll be Queen Elizabeth Hospital potentially for defence, or it could be elsewhere. And they can give information, improve the situation for the patient so they easily can be moved on and treated once they stabilise the condition. But as we develop technologies, the big holding, challenging area is that there's a need for greater bandwidth, because the digital imaging takes up a lot of bandwidth. And so that was one big challenge, is moving towards that. As you can imagine, you're dealing with patient records. You're potentially dealing with a hostile environment, so you need to ensure there's secure data transfer. So that's another challenge that needs to be addressed in dealing with the use of telemedicine in enabling treatment at the point of need, and think of the legal responsibilities that are associated with that. The project I'm working on now, which is a continuation from this, is blood. So in the UK, we have almost a critical shortage for our domestic citizens. The military are very dependent on the NHS for blood, and that's the same for all NATO countries, America, Germany. They all will rely on the supply of blood from their home nation, and that's a lot to do with regulation and so forth. So you can imagine the issues there of cold chain, flying in, able to deal quickly to a surge in demand should there be a major event. And the big problem there is the cold chain. So it's looking at how can we move towards delivery of products close to the point of need, and it might, we're trying to move away from whole blood. Humanitarian, they're very much less reliant on supply of blood from a domestic nation. They look very much on walk-in donors, which are using their volunteers or people working there to using their blood through transfer from donations and so forth. And again, there's a big problem there about testing, because you often have to fly that back or go backwards to test the blood to ensure that it's compatible, the right blood type, there's no infection. So there's a need to develop point of care diagnostics at the point of need. So another area there is looking at how you could do that in a deployed medical operation. The packaging for blood. In the UK, there's a realization that we're reliant on our blood bags all sourced from China, which can be a huge issue in terms of if there's a future conflict or trade issues. So trying to think of ways of the packaging and that issue, but also reduce the need for packaging due to the waste and so forth. And looking at other products, do we always have to use whole blood in an emergency situation? Could we just give one critical product, whether it be red blood cells or plasma or something else, to stabilize them, so you don't need to rely on this product that is very susceptible to disruptions if the cold chain is broken in any way. So looking at other ways of delivering blood. So then these are the areas that are trying to identify what the requirements are. So reliance on surge and trying to move away from the cold chain. And then the other aspect is WASH and IPC. So that's water, sanitation, hygiene, and which you need WASH to support IPC, which is infection prevention control. In that picture there, you'll see the huge number of bottles of water packaged there. It's incredible. We just didn't believe that in the first 6 weeks of an operation, they will fly huge amounts of water in from whichever country. It could be if America's running the operations, America, but the UK, they will fly that in with an average need of 7 tons per day. And you look at the amount of waste that's involved in that, the cost, it's not sustainable. And the logistics tail, if you can imagine that, you're reliant on air freight, bringing that in long distances. The environmental impact is immense, and we'll see that in a later slide. But it's needed for sterilisation of using sterilisers to ensure that products can be healthcare products such as scalpels and so forth can be used. You need it to dilute drugs and so forth. So if you add a powder to some water, obviously you need that as well. And if there's any disruption to that, it can be catastrophic, hence why they bring in such huge supplies. So there's a need to try and look at ways to produce water on demand without needing to stockpile and develop this huge and create this huge inventory of water. So that's another issue that came up during the research. So we identified those operational requirements, produced an ORD document. The next one was try to identify the points along the value chain where RDM is most likely to deliver value. So for that, we undertook value stream mapping, which I'm sure many of you are familiar with, to try and identify the value to the customer. And in terms of that, we tried to map it in terms of safety. So to ensure that at all steps, health and safety isn't compromised, and that's paramount to everything. That without those being ticked, then there's no point looking at the rest. So that is the core issue. Ensuring quality, so it's fit for purpose at the point of use. Looking at the delivery, so it's the right quantity at the right time, every time. So it's repeated, consistent. So there's no point having it delivered on time, but it's not enough to be able to deliver the needs of a hospital. And it's not right having the right amount, saying, great, we've got these supplies, but it's delivered 2 weeks too late. So that's another issue. Cost is always an issue at any modelling, but trying to minimise that cost, and not only price, but in terms of the time it's required, the space it uses up, and the handovers. The more people involved, the higher the human cost in that aspect. Looking at the people, what skill set they need. So would a new technology need a big investment in people with high skill sets? For redistributed manufacturing, that's something you want to avoid. You want to minimise and keep the it as easy as possible and to minimise the number of personnel involved, just because you're working in resource austere environment, not just because of cost. Environmental, within the UK, all public sector organisations are faced by the net zero agenda. So whether you're defence or whether you're a charity, you still need to think about the carbon footprint. So that's a key element that we considered. And time, where's time wasted during the process? So it's trying to minimise the process steps to take out waste and ensure that delivering value to the end user. So I'll show you an example. I can't expect or don't expect you to see all this, but I talked about the supply of water. And although this is one with defence, it's during a humanitarian crisis. So the situation we had here was the delivery of potable water. So by that, that's water that can be drunk, but the quality of this water is water that can also be used to wash down surgeries and so forth. So it's a certain quality of water that they need. So it's during the first 42 days in a tropical location. So in this instance, it was Mali. But so we're looking at the current supply route where they will, and the value stream map shows the movement of supplies and products, but also the information flows across there. So it will start with putting in an order at Joint Forces HQ, and then you put in an order with the supplier for the potable water, which will be taken to a site such as Bryson Autumn, where it'll be packaged, flown out, then taken out to a central distribution centre. Then it'll be unpacked, repackaged onto a truck, an EPLS, and then it'll be taken out to the camp or wherever it's needed. As you can see, it's 7,000 litres of water a day, huge amount of bottles there, several process steps, a lot of air freight involved, and so the environmental footprint is immense, the carbon footprint, and the waste is huge. That they have to decant the water at the end into much bigger containers, which results in thousands upon thousands of bottles, which they need to dispose of, which is generally through incineration. So if you can imagine the environmental costs there, it's dramatic. There's a lot of handover points where personnel are involved, and the most demoralising part of it that the personnel find the worst point is just taking the water bottles and emptying them one by one into the container at the end. So it also results in demoralised personnel working on that. So we look at the RDM, which probably doesn't look any better, but it is much better. It involves flying out a unit, which we invested, one of our research projects that we gave funding to, looked at, which can deliver water at the point of need when they need it at the right quality, which eliminates the need for, there's one flight out, but then over that 42 days eliminates the 6 flights, or so it's 12 flights, so it's 6 flights out, 6 flights back that they normally need to bring in the water bottles. There's no need to decant into, have thousands of water bottles in the first place. They can either produce the water when they need it the right amount, or they could put it into the larger containers. The offshot of this one, it also, as it was produced, one of their byproducts was a sterilising solution, which they could also use to sterilise surfaces. So it also had an advantage in that side. So it minimised resupply, repeat visits, with the bringing the goods back and forth, and it was able to respond to surges and demand. It could ramp up production to 1,000 litres a day if need be, but it's a very small unit, would take up the size of a 2-man tent or less, and it could be remotely monitored to ensure that quality was being maintained and adhered to, and it'll pick it up very quickly. Maintenance was minimal, and it just needed 10 kilograms of salt tablet to be put in every few months, but that was to ensure that it kept ticking over. But in terms of the prior model, it was much more, much less impact in terms of environmental, in terms of the travel, the number of people involved, and without having to decant bottles all the time, personnel could be freed up to do other jobs, but also their morale was improved. So if we summarize it, we did the current state over the future state. So in terms of safety and quality, that would be the same in each case. There is a certain parameters that you can't change. So it really, if we're going to do like for like, there's going to be very little difference because there is a set safety and quality aspect they have to meet. But the red flag that highlights here is in terms of delivery, they lose 10% of water at point of use just through as it splashes out and so forth. And as they decant it, you don't get that issue with the RDM application, but it can produce much more water supply, so there's more than ample if needed. 6 extra return flights, so total cost to deliver 7,000 litres per day over 42 days is £6,227,000, so £21.20 per litre. You're using the RDM, it's 198,000, well, let's say 200,000, so it's 50p per litre, so much cheaper. The traditional route uses 1,360 man hours, where the other uses only 40 man hours. The morale of the people improved, and environmentally, you can see there's 2,370 tonnes of CO2 attributed to its supply compared to 18 tonnes using the RDM approach. So through doing that approach, we're able to demonstrate that moving towards RDM for the supply of water would deliver value to the deployed medical operations in this situation. So that was one example. We looked across several areas. We looked at pharmaceuticals, we looked at medical devices, and we also, trying to remember the other one, it will come back to me in a minute. We're currently mapping blood supply, which we've been working on the past year, looking at alternatives. The final area we looked at were what are the priority areas for future research and development to ensure investment in the right area from UKRI and other funding bodies. So we undertook technology road mapping, looking across the priority areas of additive layer manufacturing, clinical fluids, cell and tissue therapies, and pharma, using an established approach by Fallon Muller, who were based at Cambridge, IFM. And I won't go through the whole step, but we undertook mapping exercises with key users, end users, experts in the area, academics, practitioners, and where needed, regulators, to try and identify where future research needed to be. And this is just an example of what we came out, which is in our final report. So we looked at the current scenario and looked at what the requirements are. And again, we traffic lighted them accordingly. So what came out across all the technology fields is that obviously safety can't be compromised. Need to work with regulators. So we've already done like the UK, but if we're looking in other countries, it's about ensuring there's comparable regulations in place to support redistributed manufacturing in deployed scenarios to ensure that you're meeting the standards and guidelines required. It might be the best innovation in the world, but if it's of no demonstrable improvement to the end user, then again, there's no need to investment is questionable. And obviously the value is not just cost, but it's got to deliver improved patient outcome as well. There's a need to look at develop pilot studies and try and look at technology platforms that exist to demonstrate proof of concept. The issue we have is trying to get applications past technology readiness 3, which you go all the way up to commercialization. So delivering pilot studies in these austere conditions to demonstrate the value of what we're doing. So we've been working with partners in that area. Looking at modularity. So as I said, it doesn't necessarily have to be specialized, but it has to be able to be repurposed or reused in different contexts and situations by different partners in order to deal with surge. So need to be able to respond rapidly to different situations. And across all of them, we're working in difficult conditions where people have to move quickly, rapidly. So any application has to be portable. So thinking about how it's looking at the unit as a whole or the product as a whole and how it's stored and so forth, it has to be portable. So it was much more in depth, the actual report, but obviously we haven't got time to go through everything in detail. I'm just covering one project at the moment, so in terms of what I'm talking to you today, so I could go into a lot more detail on this. What came out of this was the final report, which you can all find at the Rhine website. So it was a guide to stakeholders focused on bringing production close to the point of need, and the recommendations for research and development for future research. So as I said, we've mapped the capabilities and opportunities using the 3 approaches I've gone through. Key areas that need to be focused on the future is thinking about the cleaning, sterilisation aspects of these, and when we're out there, because at the moment that's very difficult to do and time consuming, so that any new product has to be able to be readily sterilised and clean. So that's something that came out as key, so it's in the report, so I'll go into that more detail. The human factors, again, nothing cannot be too burdensome in terms of training and skill set, because in these situations they don't have time and they don't have the people. They have to move quickly and rapidly. Everything has to adhere to regulation and quality control. And again, there's a need to try and think of ways to support regulations across nations in these situations. As I mentioned, we produced an operational requirement document, which is in the report, and I've gone through very briefly for all those sectors and to guide future applications. And through the value stream maps and looking at the current and future state, we looked at the business case to identify where value could be delivered using RDM. So just to show you the future pathway, so this is a standardized diagram that could be applicable to defence, military situations, to humanitarian crises and emergencies, about where RDM could deliver value. So firstly, it could be rear wards at the rear hospitals, so enabling and supporting, avoiding the need for resupply, but enabling ability to respond quickly to surge demand. But further forward, as we get closer to the situation, and improving capability and the ability to respond rapidly for those medics out in the field, and to produce the products when they need them and get them quickly to where it could be. So it's envisaged it's more those field hospitals as opposed to the actual conflict situation so much. And research is going on, not with our project, at the use of drones to deliver potential healthcare, life-saving healthcare products. So I'm going to finish just by showing you this is a paper that came out that draws on RDM and where we see it. I presented this to the Westminster Health Forum, and it's looking at will global value chain configuration through RDM offer greater resilience against disruptive events. And we looked at, in these situations, the need to respond, the need for urgency against the situation of risk. And in this current situation we're in, we see that most healthcare providers operate as global standardizers, so global sourcing, where there's long lead times, lengthy supply chains, and the focus is on standardized products and economies of scale, so centralized production. What we saw during the pandemic is that many healthcare providers moved towards global stockpiling situation and local contractors. So for local contractors, it's about looking at manufacturing sites nearby and repurposing what they were producing. So we saw that in the UK with Jaguar, Land Rover, switching manufacturing to face masks and so forth. And so that enables local sourcing, medium lead times, market-led solutions with key manufacturers, cross-sector R&D, and contract manufacturing strategies, so dealing with contracts and as and when. And they also moved to a global stockpiler, so realization that they had a lack of supplies, and so trying to create contracts with international suppliers and stockpile critical goods. So relying on global sourcing, stockpiling to order. And in the UK, the reason the pandemic that we're able to have, you might not think we have enough PPE, but we didn't, but we have more than they would have had they not been stockpiling for Brexit. So there was a stockpile in place, but that was due to Brexit. What we're suggesting is maybe we need to move to a local customizer approach, which is redistributing manufacturing, so producing the product when you need it, where you need it, so reduce lead times, and you're able to produce customized products on demand. In future situations, you know, all countries may think of providers having a portfolio approach, but obviously that would be very costly to do. So suggestion that we proposed in the paper in California Management Review is maybe we need to move towards this local customizer approach, this RDM approach. So to summarize, redistributed manufacturing has potential to meet the operational requirements for DMOs across the sectors we looked at, where there's an acute and urgent need. And able to potentially move the supply of critical products much further forward. So you're minimizing that lengthy logistical tail, which is a big issue for DMOs. So they can have more resilient supply chains, can rapidly diagnose, not be reliant on diagnosis further away, which can take time, produce and test where they are in remote conditions. The big issue is dealing with surge capacities, particularly in the current climate, blood products. So how we can move that. So that's what our research is looking at now, moving it to point of injury, enhancing capability in an austere location. Through the technology road mapping and the workshops we undertook in the interviews, it's very clear there's a need for innovation hubs where we can work on simulation and models to look at the testing of prototypes with lead or user organizations. Obviously trying to test under exact conditions like for like in these situations isn't possible, and so it's trying how can we do that in a safer environment but ensure that the products being tested, you know, rigorously. So in terms of high humidity, dust, low temperature, high temperature, so forth. So that requires close work with lead organizations. And as the value stream mapping showed with water, it has the potential to reduce environmental impact logistically and from product waste. Yet there's still need for more modelling on economic, environmental and social benefits in the future if it's to deliver on its promise. Okay, so I'm going to finish there. I realise probably giving you death by PowerPoint, and I've opened the floor to questions.
Thank you so much, Wendy. I feel like I've been transported to a different country to watch that. Very, very interesting. Do we have any questions, please?
Dumbstruck.
One thing that it just shouts out that you've got to have a kind of team approach. You don't want specialists or the specialists of, you know, someone who's going to design a fantastic product that's great but doesn't meet any of the other criteria that you.
That's one of the issues. I'm not going to say it was a very, very big university and very famous and reputable, and they put in for funding for one of our feasibility study projects, and they didn't consider at all how robust it would need to be. And it was a fantastic piece of kit, but it wouldn't work in a desert situation or in the Arctic or so. So it's those situations that have to be considered. And so for 3D printers, if they're going to be put on a ship or you know, so a naval hospital, they're going to be rolling on high seas. I know they're large ships, they don't roll, but you can imagine they've got to deal with those aspects. And they were even just saying, you know, when you've got the plasma being transfused into the arm, just the pressure can change the amount that's delivered, so and that can be a dangerous situation. So they've got to think about all those things as well. So it's factoring in the changing variables so it's as robust and fail safe and idiot proof. That's what they said, it has to be idiot proof. So you know, if the American medics are used to having a red sticker on a product and the UK medics are used to having a blue sticker on the same product, you can imagine in a field hospital there can be a huge mix-up because they're just, you know, they're trained to work under high challenge conditions, and in their mind is, oh, I've grabbed the blue bottle and use that. It could be, yeah, if they're in Americans working in a hospital that's being run by British medics, it could be, you know, it could be very difficult in terms of the outcome for the patient. So it's thinking of idiot proofing it. You know, that's even for your high level doctors. They'll just be working very, you know, very stressed, very tired. So if you don't make it very easy to use, then it can go horribly wrong. So yeah, it's one thing that you have to think about.
And you know, very interesting about the blood, but I had no idea about the water, the volume of water.
Yeah, it's. So
when you said they were taking off from Brize Norton,
yeah,
go to Mali.
Yep, Or no, or they could go to Cyprus, or they might fly to another base, or they might use a secure base that still could be 100 miles away, hundreds and hundreds of miles away, to fly in the supplies that they need. That's just to ensure that they have got water, because it's a critical product, and it's there. They're trying to secure water from a local supply, but that can take ages to get a borehole, or which they did in Afghanistan. But for the Mali situation, I mean, the biggest issue in humanitarian camps is maternal death, and that's usually through unsanitary conditions. So without that wash, you know, so the water and the hygiene control, it can be a big problem for them. So yeah, but they do fly that in at huge cost, just to ensure it's the right quality, and that it's that they've got enough. But it's a waste. It's just the burning of the bottles. It's just awful. So yeah. Or landfill. If it's biological material, they fly it back to the UK. So that's that issue about sterilisation. So if they have water to be able to sterilise, there's minimises the biological contamination, but some biological contaminants have to be flown back. So and depends on the regulation of the country and how strict they are. Yeah. So, but it's a lot of waste, and that it's heartbreak, because they were flying blood out to Mali because they need, just in case, you know, this is for the military that were giving it in case they were injured or anything. They didn't need I think somebody banged a nail into his thumb, and that didn't need a blood. He said they have to pour the blood away, and they just said, you think of the ethics of that, you know how critical blood is as a supply in the UK anyway, and if there's just pouring that away is it's quite yeah, ethically wrong. And it's been flown in, kept at in a refrigerator at the right temperature for 3 weeks at a great cost, and you just have to kind of get rid of it, because it has a shelf life of 3 weeks. So yeah, it's a lot of waste.
So you need the kind of coordination to make sure. I'll let Kenneth ask a question.
Okay, thank you. I'm just wondering, because I actually see this as a very interesting topic. I'm looking at end of the day, what improvement can actually be seen here. Is there a way of measuring the impact, the benefit that this has actually provided? Maybe looking at what has been before this period and then what it is now. If we now find a way of producing these needed items as at when they are needed, and bringing them to the areas where they are actually needed. Is there a way of statistically actually measuring the improvement, or if you have done that before? That's
why we're doing the value stream maps, and we're looking at not just sort of cost and so, but also the improvements and the outcome for the patient. So I showed you water because it's much easier one to look at, but another one that we looked at was there's one of facial orthosis. So when people get burns, so the study there was, you can take a facial scan of the patient using the iPhone's facial scanner is good enough quality. That can be sent to a hospital, and before the patient gets it, can be printed and applied to the patient. The traditional model, the thing they have to do now is the patient has to wait till they're repatriated, which takes a long time and they're quite a lot of pain. Then they have to have a plaster cast of their face, a mold taken, which is obviously very painful. They've gone through a very traumatic experience. So having something over their face is pretty awful for them as well. Then they'll make a orthosis, might not fit, so then they have to just fine tune it and fit it again. So those multiple touch points not only uses human resource, but exposes the patient to more infection. Whereas with the printed mask, which usually is right first time because they've taken a facial scan of the patient, requires less touch points, less infection, and is much less traumatic for them, and it requires less repeat visits. So the process is much they can produce a mask within 12 hours. The facial orthosis traditional route will take several days. So there's that aspect. Wound dressings as well, where they're using the patient's own cells or material to develop wound dressings and so forth. But that's a bit further off. But so looking at those ways to rapidly produce products. But even things like making splints. So when they go through humanitarian crisis, there's only so much they can take, and if you imagine a splint for a child versus a splint for an adult, huge disparity in in size and fit for purpose. So using 3D printers now, they can print off plastic splints, which are suitable for the individual. So it's so it can one that will fit a 4-year-old compared to something that's going to fit a muscly 28-year-old man. Yes, so totally different requirements there. So so yeah. So there is looking at patient outcomes as well.
There's a question in the chat from Sophin. How do you deal with the packaging for blood products once utilized?
It depends on the regulation of the country. So they call it yellow bagging. So they put it in yellow bags, and generally they will fly it back or incinerate it. It will really, everything depends on the regulation of the countries that they're in. So if they're allowed to do incineration or so forth. Other one is they dig big pits with lime, put the bags in the pits and cover it up. So it depends. The Navy are looking at whether they can use submarines to take it back to land, because obviously they have a much more difficult situation where they have to keep it on the ship, or a helicopter will have to come and take it off at certain points, or they wait till they get to land. But sometimes they'll be at sea for months on end. So yeah, so they're looking. Waste is a big issue. Yeah.
Yeah, even in hospitals, I realize, thank you for answering that. It's such a big, even the packaging for blood products, it's so thick. The bags are so thick. I would imagine it would be very hard to disintegrate or to, repurpose those.
Yeah, no, they are. That's one of the areas they're looking at, the packaging design for blood products, and because it takes up so much space. And if you're thinking of a Land Rover, we asked them why they took a certain amount of blood, and it's nothing to do with demand. It's they can only fit 30 bags in the fridge and then on the back of the Land Rover. So they're limited by that. It's not about, oh, we think they just take what they can fit. So if they could package it more, well, maybe not have to use whole blood because that takes a lot of space, but if they could package it differently, then that would create lots, be much better for them. But their other issue is that their reliance on overseas manufacturers for the bags, which is something they're trying to, or they have looked at. They've got alternative providers should they need to, but that was a bit of it was during COVID, a bit of an eye-opener that all the bags were coming from China and India, and that wasn't so much to do with conflicts. It was just, gosh, the disruption in the supply chain and having a shortage of blood bags because we're relying on bringing them in from China and India. And yeah, it was quite, it made them reconsider their sourcing strategy. Yeah.
I'll ask a last question because we must finish, but it's been fascinating. So I can imagine, say, with the military, there's a clear chain of command, but even an example you gave that the American and the UK medics must be aligned, etc. And presumably you want to see some standardization across the military context, the humanitarian context, and the emergency context. Who can do that? Who can be in charge of it?
No, but well, when it's I know for defence, whoever's in charge of the field hospital, so it could be Norway or it could be Finland, whoever, that you adhere to their regulations in the situation there. But one of the big issues, I didn't talk about it here, and one of my PhD students looking at he's just produced his thesis, is the not conflict, but the lack of cooperation between different humanitarian organisations. So sometimes they're almost competing with each other. Médecins Sans Frontières won't work with anybody because they don't want to be seen with a conflict of interest or any political, they're very on their own. So trying to get them to work together. When we were at a NATO event last year, it was about blood, actually, the big issue about regulations. And I just heard last week, we had a meeting that they've agreed that they can each use each other's blood, but they couldn't in the past. And so our Surgeon General said, when there's a real need, we'll find a way. There clearly now is a real need. They've come to agreement. But so if a UK soldier is injured and goes to an American hospital, he's allowed to have American blood transfused. But if he's injured in a UK hospital, but we don't have enough blood, but the Americans have got some, he's not allowed to use it. They're not allowed to take that blood because it's not adhering to the UK regulations. So if he happened to fall over injured and be picked up by the Americans and treated, he could have the American. I shouldn't say he, could be she, but yeah. So And the other big issue they have is, so they look at walking donors, which is, you know, using so you would have think with the military that they're very healthy, young, fit individuals and you can use their blood. But one of the first things they all do before they go on operations is have a tattoo and unprotected sex. So you can't use their blood for several months. So that's, no, I would say that's the first thing they do, but a lot of them do. So you can't be reliant on your walking blood donors either. So, and in some, for humanitarian agencies, some countries, religious and ethical beliefs don't allow for blood transfusions or blood donations. So again, they have to think about that situation. So if humanitarian, they work with what they've got on the ground, whereas if you're a military operation, you'll be flying in blood. So it's a different situation there. An emergency situation, obviously you're based in your host nation, so you'll be able to use the host nation supply. So yeah.
I feel I've had an education this afternoon or this lunchtime. The stuff I really didn't know. I must thank Akansha for organising this. Thank you, Akansha. But Wendy, that was fantastic. We could go on. I think we could go on.
I tell you, trying to put it into a presentation, I was like, oh my God, where do I start? Because I could have just done one on value stream mapping or just on operational requirements or just on road mapping. And then I thought, well, I'm trying to get the 3 areas we're trying to focus on over the course of the project covered. So, and then I could have done each of the feasibility studies. So yeah, it's good because it made me realise I have done something over the past few years. So yeah. Yeah.
Okay, I will end it there.
Thank you, Nigel.
Yeah, but thanks ever so much, Wendy. Thank you very much indeed.